So shall we start?
Sure, sir.
Okay, so just to give you a brief background of this forum, uh, this we started when I moved from SCPGI to Jaipur during the COVID time. So it is an online education portal which is primarily meant for GI surgery and HPB, MCH and DNB students, but a lot of general surgery students also have joined. And we conduct this session every week on Saturday, 9 to 10. Most of the times it is a student who presents a case, but in between we have faculty lectures and open house sessions also, where students can ask a question. So I thought that I would like to have you here. So students, you must be wondering why we are discussing uh, so-called mundane topic as fistula in ano, which all of us consider to be a minor disease or procedure. But for us, it may be minor, but for the patient, it is a very discomforting, annoying, persisting problem. And unfortunately, not many of us know about the anatomy of this region and know how to handle a fistula in ano, especially if it is a high fistula or a complex fistula. And I think there could be no person other than Dr. Pankaj Garg to deal with this issue, to tell us about the intricacies of management of fistula in ano. He has gone to the extent of uh, super specialization that even in the subspecialty of coloproctology, he has taken fistula as his area of clinical and research interest. And I can say that he has excelled in that because he is known not only nationally but internationally. He has a large number of international publications and a lot of procedures which he has described, which carry his name. So today I have specially requested Pankaj, who is also my younger colleague from AIMS, New Delhi, to tell us something about fistula and ano. So Pankaj, if you could spend about half an hour or 40 minutes, and then we'll leave some time for questions to be asked.
Sure. Sure.
Please.
Thank you, sir. Thank you so much for inviting me. And it's a great honor connecting with you. We had always heard your name, while in names as well, and afterwards. And it's really a pleasure being with you and interacting with your students. So my plan is that I should be finishing my talk within 35-40 minutes, and I shall give a brief overview about the recent advances in anal fistula, which most of the surgeons are not aware of, because not many surgeons read latest journals and so that was the prime purpose. And so let's start. Okay, so I work at Garg Fistula Research Institute, which is at Panchkula. And Panchkula is, as some of you may not be aware, is very close to Chandigarh. It's in Haryana, but it's a part of the Tri-City, which, as in Delhi, we have an NCR, in which we have Chandigarh, Mohali, Panchkula. So, and for last 12 years, um, since we started this institute, we are working exclusively on diseases of benign anorectal disorders. Before that, we were doing all laparoscopic and general surgery, but then we confined to this because we've realized that this area needs much more specialized work because a lot needs to be done. So at GFRI, we basically manages benign and rectal conditions exclusively. And in fistulas, we have invented many new procedures and new concepts and discovered new anatomical spaces, which I shall be discussing briefly today. In pilonidal sinus, we have invented new minimal invasive procedures. Hemorrhoids, even advanced grades, we have worked a lot in conservative management because hemorrhoids are so common, and approximately they say that 1/3 of the human population suffers from that. So if we can prevent surgery, it will prevent lot number of surgeries across the world. And same with fissure. So we in last 6 years we have not operated even a single patient of fissure, and we have been able to manage all of them conservatively. So today I shall be briefly touching some of the innovations done at GFRI in last 5 years. So there would be all of these have been published in the prestigious high impact journals across the globe, European and American journals, and all are available on PubMed if someone wants to read in detail, or they can text me. It shall be Garg classification. There is the outer sphincteric space, which is also known as Garg space, refill fistula, Garg cardinal principles, Tropis procedure, Garg protocol, and Garg scoring system. So coming to the first one, what is the purpose of any classification? The purpose of classification is to indicate severity of the disease and to guide management of the disease. And if we see the evolution in the anal fistula classifications, we can see that earlier there used to be past classification, and which is the till date one of the very famous classifications. Then in 2000, Morris et al. Published a new classification which was known as St. James University Hospital classification. It was basically a modification of past classification. Parks 1 was broken into 2, Parks 2 was broken into 3 and 4, and rest 3 were clubbed. So this was the first classification which was based on MRI. Because Parks, I give a lot of credit to Parks because when he worked, there was no ultrasound or no MRI. And this all classification was done on clinical experience. So this makes a lot of sense that that guy could do. Obviously, he was riding on shoulders of a lot of people who worked before him, like Eisenhower and other people. And but these people had MRI with them, and they failed to do much beyond Parks. So this was failure of utilization of MRI. And the reason primarily was this guy in Wales, um, sorry, Cardiff, he was a radiologist. And when a radiologist makes a classification, he most of the times fails to understand what are the requirements of the surgeon. That was perhaps one of the reasons that this classification didn't improve beyond Parks. Then we realized that there was a need for a new classification, and we proposed and published in 2017, which is now being very widely used and being appreciated across the world. So this is Parks classification, you all know. Basically, basically did it on intersphincteric and transsphincteric fistulas, and then 3 and 4 were supra and extrasphincteric. Then St. James University, as I told, was simply a modification of not even modification. It was almost similar to Parks. Just grade 1 intersphincteric broken into 2, grade 2 was broken into 2, 3 and 4, and rest were clubbed together. So then we realized that these classifications do not indicate severity of the disease. I will come to that, and they do not guide anything regarding the management of the disease. So that was the reason when we realized that none of the functions were being served. So, because if you see grade 1 Parks can be much more complex than grade 2 Parks, because a high intersphincteric supraelevator fistula, which is grade 1 Parks, can be quite difficult than a low transsphincteric fistula, which is just involving 1% centimeter of the external sphincter. And similarly, grade 2 high transsphincteric fistula can be difficult than a grade 3 Parks, which can be just intersphincteric supraelevator. And regarding management, these classifications do not help surgeons in any way. So that when we proposed the Garg classification, it was validated in 440 patients initially, and then further it was corroborated, validated in 848 patients. So the first classification we published in 2017 was the International Journal of Surgery, which is the very now second highest ranking journal of surgery after JAMA surgery. And then it subsequently was validated and corroborated in 848 patients just to check that this classification is accurate and is serving the purpose. So after 3 years, we published it. This was a detailed classification because when we took the first classification, it has to include everything and in as much steps as possible. But normally the working classification is slightly different, which is easy to use. It's the same classification, but for a easily working classification so that everyone can understand easily. So what difference Garg classification did? The first thing did was it moved away from intersphincteric or transsphincteric classification. It moved from high to low. And that makes sense because for a surgeon, he should first know whether fistula is high or low, rather than knowing firstly that it is intersphincteric or transsphincteric. So grade 1 is low fistula, whether it can be intersphincteric or transsphincteric with a linear tract, single tract. Grade 2 is low fistula with multiple tracts or associated complexities. Grade 3 is high transsphincteric fistula or associated comorbidities like Crohn's disease, sphincter injury, radiation exposure. And grade 4 is high transsphincteric, and grade 5 has supralevator, suprasphincteric, or extrasphincteric. So this is the example of grade 1 fistula. You can see it can be a single branch low intersphincteric or a single branch low transsphincteric fistula. Now this is grade 2. You can see they are all low fistulas. They can be low intersphincteric or transsphincteric with horseshoe tract, with associated abscess or multiple branches. So these are grade 2 because they are all low. And this is a single tract high transsphincteric fistula. This is grade 3. And then grade 3, as I said, associated comorbidities or even an anterior fistula in a female is considered complex because the sphincter in females is very thin anteriorly, and they are, after deliveries or before deliveries, they should always be taken as a complex fistula. So these are grade 4, high transsphincteric with associated comorbid complexities like multiple tracts, abscesses, or horseshoe tract. And these are grade 5, high transsphincteric supralevator tract. Supralevator tract is always intersphincteric because supralevator space is continuous with the intersphincteric space. And suprasphincteric fistula is different. Many surgeons I come across, they don't know the difference between supralevator and suprasphincteric fistula. Suprasphincteric is not supralevator fistula. It is it doesn't goes above levator. It is called suprasphincteric. It involves 100% of the external anal sphincter. The fistula goes up to 100% just above the pubitotalis, doesn't cross the levator. It curves down in the intersphincteric space and opens in the rectum. So that is a suprasphincteric fistula. And extrasphincteric fistula crosses the levator plate and opens into the rectum. We published it extensively and we give this explanation. The extrasphincteric fistulas are now become quite rare. The reason is normally a fistula will not cross levator plate spontaneously. This is quite logical because when you have so much fat here, even a huge abscess, it can occupy a huge space here, then it can go to the other side. How can an abscess generate so much pressure so as to burst the levator plate? It doesn't normally happen. It happens mostly when a surgeon, he puts his probe here in a suprasphincteric fistula like this, or any high fistula or a low fistula, and pushes the probe and makes a hole in the levator. And then just to put a theta on, especially Shart Sutra or even surgeons cutting theta on, They put a probe here, and in their eagerness to put a seat on, they push it into the rectum because their probe cannot travel like this. They will go like this and enter into the rectum. So, number one, extrasphincteric fistulas earlier were reported much higher number because perhaps they were occurring much more higher number because MRI was not available, ultrasound was not available. Number one. Number two, clinically, without MRI or ultrasound, differentiating this fistula, this fistula, and this fistula is extremely difficult. You put in your finger, you will feel that induration here or opening here, this fistula can, supralevator can open here. So practically becomes so difficult clinically to differentiate between them. So that's why uh, with the advent of MRI, we have analyzed over 10,000 MRIs. We found these cases to be extremely rare, and all of them were iatrogenic. The Garg classification was the first one, which was quite accurate in severity of grading the fistula as per severity, and it was guiding management as well. Because fistulotomy is the standard procedure, is still the gold standard for simple fistulas and can be done by most surgeons at primary and secondary level hospitals. So when a radiologist classifies a fistula as per Garg classification, and any surgeon sitting in a primary health center in a village, he comes to know that it's Garg grade 1 and 2, without even knowing the details and thing, he can go ahead with fistulotomy. Just imagine how much confidence of that surgeon will be boosted when radiologist has given him this, that this is a grade 1 and grade 2 Garg fistula. But if there's grade 3, 4, 5, he will have no hesitation in referring it to a tertiary levels hospital or a fistula expert surgeon, and he will not mess with these. Now, without this classification, what's happening is lot of routine surgeons, even Ayurvedic surgeons, are messing with these fistulas and making them much more complex and increasing their misery. And because of fear, lot of such fistulas are coming to us because surgeons were fearful. That is the value of Garg classification. So then we published this review, and subsequently this has been published in almost all top journals, World Journal of Surgery. This is DCR, which is the highest ranking colorectal journal in the world. So coming to second point, so we discovered two new things. One was a new pathway, a new anatomical space, and subsequently a new type of fistula. So this happened because in high resolution MRI is available, and we could see that we are missing some spaces which were not named or which were not being reported. We know as GI surgeons that the gut continues down into the anorectal region. The inner circular layer continues as a internal anal sphincter. The blue line is the outer longitudinal muscle of the intestine, which continues below into the anorectal region as CLM, that is conjoint longitudinal muscle. And the pelvic floor, the levator muscle, it continues down below and continues as the external anal sphincter. So that leaves us with two spaces. One is the space between the blue line and the cream line. That is the traditional, what we call as a submucous plane, but it is actually not submucous plane. This is a new space which is not normally described. But then the actual intersphincteric space is the space between CLM and the external sphincter. So this is the intersphincteric space which is routinely described as the intersphincteric space, which we will refer as middle space. So this is the inner space. So this is the middle space. What we described is a new space, which is the outer space. If you see the green line here, this is the external anal sphincter, the red one. Blue is the CLM. The cream is the internal anal sphincter. So the space between the potential space, I would say, between the fascia of the external anal sphincter and the external sphincter is the outer space, which we named as the outer sphincteric space. So this has a lot of relevance. I will come to that. This space was not described before, that what is this space and what's the relevance of this space. Because we realize that a lot of fistulas are crossing the external sphincter but not entering into the rectal fossa. They were moving here in a horseshoe space, in a horseshoe manner. They were going up in this space. So this space is a quite relevance which has never been described before. Now, if you see here, this is intersphincteric or a middle space, a fistula going between the two sphincters. But if fistula becomes transsphincteric, but doesn't enter the rectal fossa and continues in this space, this is the outer sphincteric space. So on MRI, this is a high resolution MRI which has been like magnified. So this is the inner space because this is the muscle layer, because on MRI most of the times the CLM and internal sphincter looks fused together. This is the middle space, the classical intersphincteric space, and you see this abscess is in the outer sphincteric space. So this is the outer sphincteric space. I will show more figures. This is a classical inner space, which I said between the internal anal sphincter and CLM. This is the middle space, because you can see, I go to the previous slide. In this, these were mostly referred as submucous fistulas, because the whole muscle layer is outside. Only the internal anal sphincter, which has been burrowed by this abscess, was very thin. Now this is a middle space. You see the outer anal sphincter outside and the other two muscle layers inside. And this is the outer sphincteric space. You can appreciate the yellow is the fat, and there's hardly any muscle layer outside it. So this is in the space which is outside the external sphincter, but is not entering into the rectal fossa. So we presented in ASCAR and Radiological Society of North America last year, and we published this first time in CEG. That's a good gastro journal from US, and subsequently we published the abdominal radiology, which is it is the highest ranking gastro radiology journal in the world. And once we discovered the space, we realized that there's a new type of fistula, which we described as a riffle fistula. Because if you realize the fistula going up in the outer sphincteric space will be at the inferior border of the levator muscle, but it looks inside on MRI. That's why it is inside, but it's not inside MRI. It is on the inferior or the lateral surface of levator muscle and an external anal sphincter. And it is at the roof of the rectal fossa.
Pankaj, there is a problem in the audio at your end. Can you just check the connection? We were
my connection is same. Are you not getting
me? Yes, now it is better.
Okay. Were you able to listen to the last slide, or do I go back?
No, we are able to see the slides, but your voice cracked in between the audio part.
I go back. So this was published, the outer sphincteric space was published in Abdominal Radiology Journal. And this is a new type of fistula which we described, riffle fistula. It is a fistula at the roof of rectal fossa inside the levator muscle. Actually, it's not inside. It is at the inferior and the lateral border of external sphincter and the levator muscle. So the characteristics of riffle fistula, it is a transsphincteric fistula. As I just described, it crosses the external anal sphincter, but does not enter the rectal fossa. It may, but the riffle part is when it is confined. It is infralevator, because it will go up along the border of the levator, inferior border of the levator. And it is at the roof of the rectal fossa, and it do not enter into the rectal fossa. Now, this is a very classical diagram. So this is a low transsphincteric fistula, but when you see this one, this fistula is going up. It enters the outer sphincteric space here, and then it goes up at the inferior at the inferior border of the levator muscle. So it can go up to here, and we see fistulas not uncommonly going up to the lateral pelvic wall in the refill space. And these fistulas are very important to diagnose properly if you want to manage them properly. So these are few examples you can see. This is the fistula which is starting from here, opens the suprasphincteric fistula and then a refill fistula. Now this is again a refill fistula going up at the inferior border of the levator. They are normally reported by radiologists as a high infralevator, high fistulas, high translevator fistulas, high transsphincteric fistulas, but they are not. And most of the surgeons try to manage them with normal conventional techniques, whereas in these fistulas, normal conventional techniques may not work. Now this is bilateral refill. You can see here an MRI. You can appreciate it is almost inside the levator muscle, and ischiorectal fossa is completely spared. You can see the whole ischiorectal fossa on both sides is completely normal. And if you try to approach them from below, it is almost impossible because you're blind and you will end up puncturing the levator plate. Again, another example. Here also you can see it going up to the right lateral pelvic wall. This fistula is going right laterally up to the pelvic wall. Now this figure helps to differentiate between a high transsphincteric fistula from a refill fistula. If you can see here, this is a high transsphincteric fistula, but this is a levator fistula because this fistula you can see is entering into the ischiorectal fossa and not going along the levator plate. This is the grade 4 high transsphincteric fistula, whereas this is a refill fistula. So the clinical relevance is that misdiagnosis or detection will lead to repeated recurrences. A lot of patients who come referred to me are refill fistulas because surgeons and radiologists have not been able to describe them properly. And it is a management challenging management. They are present at the top of the ischiorectal fossa, and approach is very difficult. And they can be confused with either supralevator fistulas or a high infralevator fistulas, and confusion can lead to either injury to the levator or repeated recurrences. So we published the same thing in abdominal radiology as refill fistula, high complex and fistula diagnosed by MRI. A lot of radiologists from across the world then started mailing me. Yes, we were seeing this fistula, but we were not sure how to report it since there was no terminology. Because radiologists see this fistula much more commonly than we surgeons, because we surgeons don't have penetrating eyes to see fistula at the roof of ischiorectal fossa. So this now coming to the medical management, and in this I shall be discussing about the new principles of fistula management, especially the complex fistulas. If you have abscess anywhere in the body, let's say a thigh or forearm, how do we manage it? Because I always say that never leave the basics. When we start thinking hi-fi, gadgets, we go away from basics. So the important thing is not to go away from basics. So one of the reasons in 100 years, nothing significant could happen in fistulas was that we were perhaps not focusing on ignoring the basics of abscess management. So if we have abscess anywhere in the body, how do we manage it? Either antibiotics alone, we can do needle aspiration plus antibiotics, and even we can do IND of the abscess, but we do not do cruciate excisions. And why cruciate excision was classically described more than 150 years back? Because they realized that if you do only incision and drainage, the edges might stick together and it would be similar to this. And even antibiotics if there's a big abscess, they don't help. The reason was that deroofing was important because drainage one time is important, but we need to ensure continuous drainage of pus or collection in the post-operative period till the abscess cavity heals. Because in all these three methods, the problem is that when you drain the abscess and you don't ensure drainage in the post-operative period, some fluid will collect inside again, and you cannot eradicate bacteria immediately, so they get infected again, and abscess comes again. So this common principle we all learn in our internship, that abscess needs to be drained and it has to be ensured continuous drainage in the post-operative period. So this is the basic abscess principle which we all know and follow. But when we come to fistulas, this was completely ignored. What new thinking what we gave was that we realized that this is the like internal anal sphincter, this is the external anal sphincter. The fistula tract in the intersphincteric space between the two sphincters is like a abscess in a closed space, because this is full of maybe little pus but full of bacteria, and this is between the two muscle layers. So this is abscess in a closed space. So once we realized this, and we started managing fistulas like this, it the fistula treatment became quite simple. I'm talking of complex fistulas. So this we name as ISTAC principle, and ISTAC principle is that intersphincteric tract should be treated like an abscess in a closed space. And we know that in our gut, any dural fistulas, ileal fistulas, there's a basic rule, basic principle that if the distal gut is patent and there's no obstruction, there's no infection, the lateral fistulas would close most of the times. But in fistulas, if they just imagine the fistula is closed most of the times because of the anal canal is closed most of the times, and there's an abscess sitting on the lateral wall, the fistula will never close. So these were two cardinal principles which we gave, that ISTAC intersphincteric tract is like an abscess and closed space and should be managed like one. And then not only management, but like any other abscess, it needs to be drained of all pus or infection. And most important, it has to be ensured continuous drainage in the post-operative period. So once we understand these two principles, we understand all the new gadget-driven principle procedures like fibrin glue, plug, waft, clip, laser, stem cells, why they don't work in complex fistulas, because these procedures do not attempt even to treat intersphincteric component. Because in fistulas, you need to treat the internal opening as well as the tracts, as well as the intersphincteric component. So lift procedure was the first one which started addressing the intersphincteric space and the intersphincteric tract, but it was not falling draped because it was draining the intersphincteric space, and then it was something like that. It was allowing it to collapse. Therefore, lift had moderate success rate in complex fistulas. So we realized that the procedure which needs to take care of these two procedures principles. That was we published in Medical Hypothesis, and that's why at the time we invented TROPIS procedure, and which has shown to be quite effective because take care of both these cardinal principles. TROPIS stands for transanal opening of intersphincteric space. So preoperatively, MRI is done for accurate assessment of internal opening, intersphincteric tract, and external tracts. And then it is very similar to lateral internal sphincterotomy. It is basically an open LAS at the level of internal opening. Just to explain, basically intersphincteric tract needs to be opened. So basically there are we have divided fistula into two parts. lateral to ES and medial to ES. So medial to ES is the intersphincteric tract. So that is laid open by putting an artery forceps inside the intersphincteric plane. And when this is not locatable, we'll follow Garg protocol. I will come to that. And when it is lateral tracts can be done by any method like curettage of tracts and put a tube. You can do laser ablation. You can excise the tracts, whatever method the surgeon is comfortable with. So intraoperatively, you find the internal opening, insert a curved artery forceps through the internal opening in the intersphincteric tract, lay open the mucosa with electrocautery or laser, and external tracts are curated, and a tube is put in the long external tracts to keep the external opening open, because the purpose is to heal the internal opening by secondary intention. So this was the paradigm shift which we created. Was first, the intersphincteric tract need to be tackled, because there in transanal drainage of abscesses was described 75 years back, but that was only a drainage. They never understood the concept, which the ISTAC principle, that all fistulas have some intersphincteric component, especially the complex ones, which needs to be tackled. And secondly, the paradigm shift which we moved into was that all procedures were trying to close the internal opening primarily. And we as surgeons know that whenever there is an infection, we always prefer healing by secondary intention, because we know that in the presence of infection, the primary intention closure becomes quite difficult. So that's why TROPIS was the first procedure which started and tried to deal with internal opening healing by secondary intention in high complex fistulas. So this is again the simple diagram, and this is the intersphincteric tract. We put an artery forceps inside here and you lay it open, and this is the final wound. You have a small wound inside the rectum. This is the intersphincteric tract which has been laid open. A small gutter is made so that it keeps drained in the post-operative period. So this is a final picture of a high complex fistula. The tract has been curated and a tube has been put. We suture it and we take out the tube after 3 months once we ensure that this has healed. So we have done 645 patients in a series, and the median follow-up is around 5 years. They are all MRI proven high fistulas. Not even one was a low fistula. And most of them you can see are recurrent fistulas. 1/3 were supralevator fistulas. 1/3 was horseshoe fistulas. And almost all of them had multiple tracts. So after first surgery, 80% healing was obtained. And then second surgery was needed, and we repeated the TROPIS procedure, and overall healing was 90%, and there was no change in continence. These are presented extensively in American Society meetings, all these papers, and we published it extensively in all top ranking journals. And so this was first published in International Journal of Surgery, and the first time in 2017 in which we published our first experience in 52 complex fistulas. And subsequently in DCR, we published only an exclusive cohort of supralevator fistulas. And then 2 years back, we published in colorectal disease in 325 patients. And then this is the largest series of fistulas published in world literature, 1250 patients, out of which 408 were high complex fistulas. And recent meta-analysis of all the surgical procedures, sphincter sparing procedures for complex fistulas was done last year by Huang et al. And they concluded that TROPIS is the surgical method with the highest cure rate. Of all the sphincter sparing procedures being described in the last 120 years, they found out in their meta-analysis that TROPIS is the best procedure. Now, lift is also a good procedure, but at TROPIS and lift, I won't say they are at loggerheads, but they are complementary to each other. So that was time we compared, and it always, if you're describing something, if you don't compare and you don't reevaluate, then there's no point. And so in certain patients, like this is a fistula with a high transsphincteric fistula, but intersphincteric component is quite less. You can see this one. So in this lift, I would say, would be the first operation of choice. The reason being you will be not even cutting even slight internal sphincter. But whereas in such a high intersphincteric fistula with an abscess, a TROPIS would be a better operation. Same in this one, a high suprasphincteric abscess, it is so difficult to reach here to do lift procedure. So here TROPIS would be a better option. So we published this in World Journal of GI Surgery last year, the comparison between the lift and the TROPIS and how both of these procedures are helpful to the operating surgeon. Now, a simple new protocol to effectively manage anal fistulas with no obvious internal opening. This has been published that risk of recurrence is more than 50% and is 20 times higher if the internal opening is not found. And a recent paper found out the relative risk of fistula recurrence that inability to find internal opening was associated with highest relative risk. And surprisingly, when we realized that there was not even a single study which was in the literature how to manage such fistulas. And we did a prospective control trial and we divided them into two groups, study group and the control group. And the primary outcome parameter was fistula healing. And how did we define? We tried these methods to locate internal opening, preoperatively, and then examination and anesthesia before surgery, and then putting a colored solution and MRE assessment. When all of them failed, we put them in the study group that internal opening was not found. The Garg protocol is simple, that in a horseshoe fistula, we assume that even if it is not seen on MRI, it will be in the midline. If it's a posterior horseshoe fistula, it will be posterior midline. If it's anterior horseshoe fistula, it's anterior midline. And with the non-horseshoe fistulas, we analyze the MRI again. We see where the fistula tract is reaching nearest to the external sphincter. So it was assumed that the fistula opening is at that point, and fistula was managed appropriately, assuming that. So this is quite logical. If fistula is reaching at a particular point, but not opening into the rectum, because it's most of the time you are not seeing the opening, it's so fine. And we followed this protocol. Like this is a few examples. This is a normal fistula, classical opening at 6 o'clock. Again, 5 o'clock to 6 o'clock, clear cut opening. But here, again, a classical opening at 7 o'clock. But here you can see, it is going from almost 5:45 to 6, but not opening into the rectum. So obviously it would be, the opening would be around here only. And this, again, this is the fistula tract going from right striatal fossa up to 9 o'clock position, but not opening into the rectum. Again, posterior horseshoe with a big abscess, but the internal opening is not clearly seen. So the procedure we followed was that if it's low fistula, we did a fistulotomy, high fistula, we did TROPIS. And in 75 patients, these was the 154 were in the study group and 546 was the control group. These were the group in which no internal opening was found. And they were quite similar in all other parameters. And if you see the success rate, it was quite similar in both the groups, around 90%. And the incontinence scoring, objective continence scoring by Vasey scores was also very similar in both the groups. So this was the first study on this topic. It was a prospectively controlled trial, and all parameters were similar, and fistula healing rate was similar, and change in continence was also similar. The Garg protocol is quite safe and effective in managing fistulas with non-locatable internal opening. Presented in SCAR 2021 and subsequently published it, a simple protocol to effectively manage fistulas. And then we published this Garg protocol in the same journal with in abscess patients. That because internal opening is more difficult to found in abscess patients, and we found this protocol quite effective in those patients as well. Last, I will run it briefly. We know fistulas. The problem is that it causes anxiety in the mind of patients as well as surgeons, because even after apparent healing, the fistula comes back. The surgeon is never sure the fistula is healed. That was the time we realized that a classification scoring system is needed to assess post-surgical healing and to predict long-term healing in cryptogranular anal fistulas. So, as I said, they cause great uncertainty and anxiety in minds of patient because the inability to accurately confirm fistula healing after surgery or confidently predict long-term recurrence-free healing. So MRI, we realized, was quite accurate to evaluate fistula healing, and there was no scoring system which could predict. So this scoring system, what is to be done at 3 months post-operatively, and 6 parameters we described. We did follow a very strict statistical method, and all analyzed parameters responsible for healing were shortlisted. A weight was assigned to each parameter, and then a pilot study was done to decide cutoff. And we came to 6 parameters: 4 post-operative MRI, four post-operative clinical evaluation at 3 months. That's most important. So maximum weight was given to each parameter, and maximum score is possible is 20, minimum is 0. So we realized that if the score is less than 8 at 3 months post-operative, the prediction is the fistula has healed and will remain healed on long-term basis. And the score is more than 8 or equal to 8, fistula has not healed. Even the clinically fistula looks healed and it would recur. So that's the value of this classification. These are the parameters. The 4 MRI-based parameters are healing of primary internal opening, healing of fistula tract in the intersphincteric space, healing of external tracts, new abscess, and clinical was flatus passage or amount of pus discharge from the fistula tracts. These are 6 factors which evaluate healing. So 537 patients were included in the study, 152 finally were qualified. And what we realized was that this was very accurate in 143 patients. So if you see, the true positive predictive value of this scoring system was 98.2%. And the negative predictive value was 83%. So this is very important. This means the reason for this is that when the scoring system predicts healing, fistula will likely to remain healed. So that's the main value of this scoring system. But if the value is less, the healing can still occur. The reason for that is we have taken cutoff at 3 months, and not all fistulas heal at 3 months. So fistulas can still heal at 4 months, 5 months. So that's why the negative predictive value is not that high. So the value of this is that if the positive predictive value is high, that when this scoring system shows that fistula is healed, the fistula will remain healed. So you can tell your patient, and you can yourself be confident that fistula will remain healed. So this is a useful tool for surgeons and radiologists managing anal fistulas. It can ease and streamline management, and it can reliably predict recurrence-free healing. And one factor I have not mentioned here, any new procedure comes, like plug came, glue came, first the graph goes, waft came, the graph goes very high, and then after 5 years it comes down, wasting so much money, resources, time, patient morbidity. So any new procedure comes, you do this scoring system at 3 months. So within 6 months, it would be clear whether this new method would be helpful or not. So we published this in CG, and subsequently this was done. A prospective study was done. That was a retrospective study, and we found that but a positive predictive value in this was 100%. Thank you so much. And innovation helps. And recently, in a textbook from France, all surgeons who have contributed in the field in the advancement were listed, and we were included in that. And this is my favorite slide. Anything done with passion becomes an art. Thank you so much.
Thank you, Pankaj. Thank you very much.
My pleasure.
So I think, as I said in the beginning, all of you must have realized that how if you take any area, even if it appears to be minor, mundane, neglected, and if you put your heart into it, then you can help the patients because these patients keep going from one surgeon to another. And although it's not a life-threatening condition, but it is a difficult condition which affects the quality of life. And it requires detailed knowledge of anatomy and now radiology, and then following the basic principles as Pankaj highlighted. So, for the sake of students, I would summarize that whenever you are dealing with a fistula in NO, there are few things which you have to keep in mind, as Dr. Pankaj has highlighted. One, its relationship to the sphincters, both internal and external, the relationship to the levator muscle, which is a very important landmark. So basically the height of the fistula, the number of fistulae, single or multiple tracks, the shape, whether it is linear, horseshoe, or zigzag, because if it is zigzag, as Pankaj said, that no attempt should be made to try to probe the fistula, because then you can complicate it if your probe pierces and creates a false track. Whether there is an associated abscess, uh, although he didn't go into details, but he did mention in passing that you have to keep looking for associated diseases, Crohn's, HIV, and other issues, tuberculosis in our country. And obviously, when you are dealing with a recurrent fistula, it becomes a difficult issue. So before I open to my colleagues here and online students, 2 or 3 quick questions, Pankaj. So do you recommend MRI in all fistulae nano?
Sir, normally I won't, and because it becomes a costly affair, but I do because most mine is a referral practice, and we one of the papers we showed that that was published in World Journal of Surgery in 2018, and we did that. That is a very important information in about 230 patients. So clinically, we realized the value of MRI in clinically simple and clinically complex fistulas. So obviously in complex fistulas in 62% it adds much more value. But what was really surprising uh, finding was that 1/3 of simple looking fistulas on clinical examination turned out to be complex, high fistulas on MRI. So this call has to be taken by the surgeon that he is very confident that it is a simple fistula, but 1/3 of them, it has to keep at the back of the mind, they can be complex. So even if it's a simple looking fistula, during surgery, you feel it's complex with a 1/3 possibility. Don't mess up. So because and the other advantage in India is our MRI is 5,000-6,000 rupees. We are blessed that way because in US and Europe, the fistula is $4,000 to $5,000 because the manual labor input when the radiologist reports so many charges, so they cannot afford it. So initially I sent them publications and I write it should be done every patient. I would used to get violent reviews from the reviewers. When I say violent, it was like literally like, how can you even think like this? MR is so costly because I am doing so. I was advocating what I am doing. So then I realized no, you can't because you have to understand the problems of that area. So not MRI. MRI may not be. Then a lot of people say that it's so costly. I always say it's cheaper than a reference. So, but it is call of the surgeon. But this they have to keep in mind that all complex fistulas, recurrent fistulas, MRI should be done. All simple fistulas, if MRI not possible, keep at the back of the mind. The 1/3 of them can be complex.
Yeah, but personally, I thought, and now I'm more convinced after hearing your talk, that you cannot make out the type of fistula unless you have a good imaging. Clinically, it is very difficult. So I
Absolutely.
presume, ideally, all fistulae should have an MRI.
That's
Uh,
right.
so in your classification, what is the cutoff of low versus high?
It's a involvement of the external sphincter one third.
So
One third
if
of
it is
the
less than
external
one
sphincter
third,
is
it
low
is
fistula.
low.
More than one third, it's
So again, this cannot be delineated on clinical examination, isn't it?
absolutely,
You have to
absolutely.
have an imaging. And second, in your classification between group the grade 1 and grade 2, why have you created these two grades? Is there a difference in the management?
No, they can be clubbed, but grade two is slightly more complex than the grade one. Just imagine a simple low transsphincteric fistula with 1 centimeter involvement, or the same fistula with an associated horseshoe tract. A little more care from the surgeon is needed, that he needs to open the horseshoe tract, thoroughly debride it, or the associated abscess. So that's why even in the same two grades can be managed by fistulotomy, but there can be grading that you have to be a bit more careful. It's a slightly more complex.
And just for my personal knowledge, you showed some line drawings of CT and MRI images. So is it hand drawn or is there a software to do it? Because I have been looking for it. The
Line
real
drawn.
image, and below that there was a line drawing.
Oh, they're done by me, sir. Because MRI doesn't show them. I have to make a what do you say, schematic diagram and superimpose them
So this
because
is
for
hand
some
drawn. This is
uh,
drawn by hand,
the,
or
the MRI findings were hand drawn.
no, no,
Then,
the lines, the MR.
no, no, no,
Can you
no,
go?
no. Then we basically take the MRI pictures and then make a sketch out of it.
So it is done by the software.
Software sketch out of it, and then MRI findings are hand drawn.
Yeah, the coloring you have done hand drawn,
Yes.
but the
Yes.
background
Yeah,
is
yeah.
a
Sketch.
software.
It's a sketch. It's a software. Sketching is it converts into sketch. There are a lot of software available. You can
Okay.
make your face,
Because
turn it to
I
a
have
sketch.
been looking for it for my
Okay.
book. Okay, thank you. So my colleague, Dr. Vinay Mahala, he wants to.
Good morning, sir.
Hi.
Sir.
Hi, Vinay.
Sir, first of all, thank you very much, sir. Such an elaborative session for this complex fistula, sir. Because even being as a GI surgeon, it is very difficult to deal with these kinds of fistulas. So, sir, if it is possible, can we have some of your good videos? Obviously, all of your videos are good, but can we have some of standard videos of Tropis procedure?
Yeah, I can look for them because I have not formally made them, but I can look and we can share definitely.
Sir, I will mail you, sir, the if it is possible. And simultaneously, sir, what is your experience about laser surgeries in these complex fistulas, sir?
Look, laser, as I said, they are gadget-driven procedures. I tell to my patients that these are instruments. The basic principles need to be followed. A lot of people, because laser is selling around, because people who do buy a laser machine then advertise it very rampantly. We have laser, and the perception of layperson is that laser is something like a spray. They spray it and fistula becomes all right. Because patients won't realize that laser is ultimately a coagulating or a cutting instrument. And we have patients coming to us who have been rendered, sphincter has been cut with laser. So laser is just a instrument. So if you follow what procedure you do with laser, if you plan to simply coagulate the tract with laser, it's not going to be helpful. Maybe simple fistula, it will. But when we talk of complex fistulas, it doesn't add much add benefit at this stage.
And sir, what is your routine practice regarding that cutting and draining setum, sir?
I don't, because we are managing all abscesses in the single go. As I said in Garg protocol, also we showed that we are managing all abscesses in the single go. So normally draining cetum, cutting cetum, we strongly criticize, and draining cetones we need to put when we need to drain the abscess or acute stage and then do at a chronic stage. But in like all other conditions like cataract, now things are prostate, that waiting and letting the tract mature, I don't think that is needed. All abscesses are coming to, if you know the anatomy well, we all abscesses coming to us, we treat them with a single and with the intention to treat them in the first sitting.
It's how much is your personal experience of recurrence in those cases of abscess without internal openings?
Oh, that paper I will share with you. The success rate is similar, 90 to 92%. Abscess, I'm talking high fistulas, not low.
Yes.
Abscesses with no internal opening, 91, it's around 191%. We published that. I will share you that paper.
Recurrence within a year or after a year?
When I say success rate is 91%, the recurrence is obviously 9%. And so the recurrence is,
yeah. So what is your protocol of follow-up of those patients, sir? Those patients?
Recurrences.
No, for those complex fistulas without an internal opening presented to you with the abscess, how much time you use to follow up those patients?
I follow them indefinitely, even the patients who have healed. That's if you have to publish, you need to follow them up. Even after 10 years, we publish. We have now we started GFR in 2008. Before 2009, I don't have follow up. But after 2009, all patients are followed up. Every year or alternate year, a phone call goes from my center and takes them, because when I have to publish, I call them afresh. So I don't leave follow up of any patient.
Okay. So, sir, it's my humble request. Do we have privilege to have your Propis videos, if it is possible?
Sure.
We will mail you, sir. Thank you very much. Thank you.
Congratulations, sir. Wonderful presentation.
Yeah, that's Dr. Rajendra Desai from Hyderabad. Yeah. Yes, Rajendra, go ahead.
Yeah. One thing we all need to do is reread your classification in the journals. So I have privated you on ResearchGate for your full text publications. And it seems to be path-breaking. Actually, intersphincteric component seems to be very, very important, even in my experience.
Right. Absolutely. So you got access to Dr. Desai to the classification, or you need me to send you the papers?
I need you to send me the papers.
You can write my WhatsApp number and just message me. I will WhatsApp you, or you can. WhatsApp is easier.
Pankaj, you send it to me. I'll put it on the group.
That's fine.
For the benefit of all the students.
Perfect.
Yeah. General Chaube wants to ask something, my senior colleague here.
Dr. Pankaj, good morning. It was a fantastic talk. But one thing I think the message should be that because the basis of your classification is totally on MRI, and MRI has definitely revolutionized the treatment of fistulas. So I think that all surgeons should be told that, because after all, quite a high percentage, 1/3 of the patients which were presumed to be without MRI to be low fistulas or simple fistulas turned out to be complex. So I think, and then they become the big numbers for developing complications and recurrence. So I think MRI should be advised. And one thing, the one point which you very succinctly told, the importance of all efforts should be made to localize the internal opening, because that is a state. Because internal opening, definitely the tropis, the internal opening is a state. It should not be just left that internal opening could not be localized. Then you run the risk of doing the incomplete treatment.
Absolutely, sir. I showed the previous studies that when the internal opening was not locatable, the risk of recurrence was 20 times higher. And it is the single most important factor of recurrence when the surgeon is not able to locate the internal opening.
I think we'll close. We are already 10 minutes beyond our time. So thank you once again, Pankaj. Thank you very much. And as Vinay wanted, either you can send the video, or if you would like to show the video or a procedure, then we will have to kind of make an arrangement.
Definitely, sir.
Thank you. Thank you.
Thank you, sir. Thank you so much. Bye-bye.
Okay, we will close the session.